everyone. Welcome to the Flash Revision YouTube series of the Surgical and Post-op module. I'm Dr. Shamni from StudyMEDIC, your mentor, and I'll be taking you through the Surgical and Post-op module. Let's discuss some SBAs and EMQ. What insufflation pressure should be achieved during insertion of primary trocar? So initially, let's discuss about laparoscopy and hysteroscopy. So go through all the options. During insertion, it is going to be 20 to 25 mm Hg. So a 38-year-old woman with previous midline laparotomy is planned for laparoscopy. What is the safest primary entry site? Because she is having midline laparotomy, we have to go for Palmer's point. So let's discuss the insertion techniques and the insufflation pressure. So the closed varus needle technique is one technique where the vertical incision is given at the base of the umbilicus and the needle is inserted at 90 degrees. We have to listen for 2 clicks, that is fascia and peritoneum, and avoid any lateral movement. And safety confirmation, so many methods are there, but out of the most reliable is low initial insufflation pressure of less than 8 mm Hg. The insufflation pressure during trocar is 20 to 25 and after trocar during surgery, it is going to be 12 to 15. This is a very important area for questions. So the primary trocar insertion, there are various methods. So after putting varus, you can put primary trocar at 90 degrees through the umbilical base, stop immediately on the entry, and we have to rotate the scope in a panoramic view of the peritoneal cavity should be obtained to see for any adherent bowel or any retroperitoneal hematoma. The open or the Hassan's technique is there where you're going to there is direct visual entry and a blunt trocar is usually used. And here you are going to put a facial stay sutures and facial closure mandatory at the end. That is very important. Advantage is that it avoids blind sharp entry. Disadvantage, bowel injury is still possible, but it is comparatively less. Palmer's point, where is Palmer's point? It is located 3 cm below the left costal margin in the mid-clavicular line. But this has to be avoided if the patient has undergone a splenectomy or any previous upper abdominal surgeries. The secondary ports usually is inserted under vision and the pneumoperitoneum during secondary port insertion also remember it is going to be 20 to 25 mm Hg. Only during surgery it is going to be less. And before insertion of secondary port, visualize for inferior epigastric vessels. So in obese women, we may prefer Hassan technique or the Palmer's. And we have to remember that the varus needle vertical incision should be given at the umbilical base. For very thin ladies, because the aorta remains close to the anterior abdominal wall, it is better to go for Palmer's. So which port requires facial closure? So the answer is C, 10 mm lateral port. So you have to remember that 7 mm, more than 7 mm lateral port requires closure. More than or equal to 10 mm midline requires closure. The major complication, the most exam specific points, the major complication during laparoscopy is around 1.4 to 2 per 1000 procedures. The port closure we already mentioned. And the complication rate is very important. We have to know that the bowel injury chance is 0.6 to 1.1%, vascular is 0.1 to 1, and urological is 0.3. So out of this, the most common is bowel injury. A 45-year-old woman is undergoing laparoscopic procedure. She has had a previous laparotomy with midline incision. So the incidence of umbilical adhesion is? So the answer is 50% because she had a midline incision. So if she had a transverse lower incision like Fannin steel and all, still there is a chance and it is going to be 23%. So let's discuss this EMQ. A junior trainee is doing her first laparoscopy on a nulliparous woman with a BMI of 29 and no risk factors. ST2 doctor has checked all the equipment and must now make an incision for the introduction of the varus. So we know that the varus incision should be at the base of the umbilicus. The first option itself is the answer. Next question. A 32-year-old woman with a previous history of midline laparotomy is going a laparoscopy. Senior specialty trainee is teaching the junior specialty trainee to introduce a laparoscope. Junior trainee inquires about the exact location of incision. In order to introduce the varus needle, what is the most appropriate choice? It is going to be the Palmer's position, and it is 3 centimeter below the left costal margin in the mid-clavicular line because of the previous midline incision. So, these are important areas during laparoscopy where you can get question. Diagnostic laparoscopy consent advice is very important. The frequent risks, they usually ask, what are the frequent risks? So, the frequent risks include wound bruising, shoulder tip pain, there may be wound gaping and wound infection, and larger procedures like extra procedures like laparotomy, bowel bladder repair, etc. You have to take consent. Blood transfusion consent also should be taken. What are the serious risks? Serious risks we already discussed, it is 1.4 to 2 per thousand, and these include bowel, bladder, uterine, major blood vessel injury, death. 15%, we have to remember that 15% of bowel injuries may not be diagnosed at the time of laparoscopy. Failure to gain entry, then hernia at the site of entry. Death is, the rate is very important, 3 to 8 per 1 lakh. What are the, this is regarding pregnancy and laparoscopy. So there are some risks in pregnancy if the patient undergoes laparoscopy in conditions like appendicitis, cholecystitis and all, where you have to treat it. So the surgical risk and anesthesia risk both are there. Increased risk to the vascular and organ trauma because of the enlarged uterus, reduced field of vision, limited access are there, and uterine perforation may occur. So if it occurs, there can be preterm delivery, infection, laceration, bleeding. So all those other complications. So direct fetal risks are also there, like fetal hypoxia secondary to maternal hypoxia or hypertension, or hypercarbia may cause fetal hypoxia, and reduced uteroplacental perfusion may be there because of the increased abdominal pressure and the maternal positioning. Preoperatively and post-operatively, you may listen to the fetal heart or do a CTG. Continuous intraoperative CTG is not usually required, routinely required, and anti-D prophylaxis should be given for Rh negative women. So these are the tips for laparoscopy in advanced pregnancy. It should be done by an experienced person. Antacids should be given. NG tube insertion we can consider. Lateral tilt to avoid aorta cable compression should be there. Prefer Haysen's entry. Palmer's point also may be considered. Consider the use of ultrasound to facilitate entry, and the operating pressure should be less, like 10 to 12 millimeter HT, and we have to auscultate the heart before and after surgery. So let's discuss an EMQ. A 34-year-old woman undergoes diagnostic laparoscopy for chronic pelvic pain. She is counseled preoperatively regarding the complication. She is informed that a proportion of bowel injuries may not be recognized during surgery and may present later with abdominal pain and sepsis. So basically, they are describing the undiagnosed bowel injury at the time of laparoscopy, which occurs in 50% of cases. 28-year-old woman at 18 weeks gestation undergoes laparoscopic appendicectomy. During trocar insertion, limited visual field access was there due to uterine enlargement and risk of direct injury to the gravid uterus. So most specific maternal risk in this situation is F, that is uterine perforation. 39-year-old woman is scheduled for, let's discuss the topic hysteroscopy. So here the patient is scheduled for hysteroscopy for AUB. She has no comorbidities. She is anxious and asks what pain medication you are going to give her before the surgery. So the best analgesic is oral NSAID, which has to be given 1 hour before the procedure if there is no contraindication. So a 47-year-old postmenopausal woman is planned for outpatient hysteroscopy. She has a history of difficult cervical dilatation during previous procedure. Which statement regarding cervical preparation is most appropriate? So definitely, cervical priming should be routinely used for all women. That is wrong. Vaginal misoprostol should be given 3 hours before the procedure. So according to the new guideline, that is also wrong. And the answer is cervical priming should be considered only when cervical stenosis is anticipated. Okay. We will discuss that in detail. During OP, outpatient hysteroscopy for endometrial polyp, which uterine distension medium is generally used? It's normal saline. So analgesics, let's discuss. So it's going to be oral NSAIDs 1 hour before procedure. And if NSAID is contraindicated, you may consider oral opioids, or TENS is also another option, antispasmodics also. Inhalational analgesia Enternox is also available. So cervical preparation, the guideline says routine use is not recommended. We have to consider only if there is cervical stenosis, need for dilatation more than 6 mm, large diameter of the hysteroscope used. And if at all you are giving some vaginal misoprostol, it is going to be 12 hours before, not 3 hours. And remember the side effects of misoprostol. The hysteroscope choice is for diagnostic, it is less than 3.5 mm outer diameter. This is a usually asked question. Operative use smallest diameter possible. Expandable outer sheets are usually preferred because of lesser pain. Flexible causes lesser pain, but sometimes it may be difficult to do. Rigid, better image qualities, you can do it fast, but sometimes it may cause more pain. The operative devices for each procedures, like for endometrial polyps, usually mechanical hysteroscopic removal tissues removal systems are usually used. It is preferred over bipolar electrodes. For uterine septum resection, mechanical mini scissors are preferred over bipolar electrodes. Endometrial ablation, actually the device choice is based on the expertise. So this is a frequently asked area, that is fluid deficit. You know that fluid deficit, fluid overload is one of the complications of hysteroscopy. And if the fluid deficit is more than 1000 ml when using hypertonic solution, and fluid deficit is more than 2500 ml when using isotonic solution. This applies to healthy women. Remember, healthy women, this is the range. So the incidence is around 0.1 to 0.2 percentage. So this is how you have to do. Less than 500 ml, you have to continue the surgery, no harm. 500 to 1000, inform the anesthetist, you can continue the surgery, but I have to expedite the procedure. 1000 to 500, 1500, again you have to expedite the procedure, but here you check the electrolytes, urea and electrolytes. See if the serum sodium is less than 125. If the serum sodium is less than 125, procedure must be terminated as rapidly as reasonable. And we have to catheterize the patient and consider furosemide. 1500 to 2000 also same like this only. But if it's 2500, you have to give furosemide IV and we have to consider terminating the procedure. And more than 2000, definitely you have to terminate the procedure. And if the serum sodium is less than 120, you have to manage the patient in critical care setting. So these are the types of the media used: isotonic electrolytes and hypertonic non-electrolytes. Example of isotonic is normal saline galactate, hypertonic is glycine 1.5%. So the isotonics for normal saline for healthy women, maximum deficit is 2500. For cardiac and renal deficit, it is 1500. For hypotonic, healthy women, maximum is 1000, and for cardiac and renal disease, it is 750. And remember, for hypotonic, if it's 500 ml, we have to inform the anesthesia. 750 ml for cardiac renal stop. Others 1000 we have to stop. So let's discuss a question. EMQ, the 38-year-old woman undergoes operative hysteroscopy, hysteroscopic polypectomy using NS. The fluid deficit reaches around 1000 ml, but she is hemodynamically stable and asymptomatic. So here we can continue, inform the anesthetist and expedite the procedure. Answer is B. A 40-year-old woman undergoing operative hysteroscopy with glycine develops confusion, coma. Okay, already hyponatremia is there, 118. Fluid deficit is 1800. We already discussed this before in our chart, and it is going to be stopped, the procedure definitely, and the patient is going to be managed in HDU and ICU. So 30-year-old woman undergoing hysteroscopic septal resection with normal saline reaches 2500. She is asymptomatic, stable, but still we have to stop the procedure and give IV furosemide. So the answer is E. So regarding the next topic, that is the nerve injuries. So different types of injuries are there, like neuropraxia, axotomesis, neurotomesis. And we have to remember that neuropraxia usually recovers within weeks to months. Axotomesis will take longer, usually several months. Neurotomesis has got very bad prognosis. So the summary of the lumbosacral plexus is very important. So here you have to know from where each nerve originates. So femoral nerve, it is L2 to L4, and where it supplies. Like you may get a question like this. So the sensory function will be affected on these areas. So you have to remember that for femoral nerve, it is going to be anterior and the medial thigh and medial aspect of the calf. and patient won't be able to climb the stairs if it's affected. So the motor function will be usually hip flexion and adduction and knee extension. In obturator nerve, it is L2 to L4, the upper medial thigh, and usual action is thigh adduction. So minor ambulatory problems might be there. Sciatic, it is common peroneal or tibial, L4 to S3. So below knee except medial foot, lateral calf, dorsum foot, toes, and plantar surface of the foot. So this is the area distributed, and if at all the sciatic nerve gets damaged, it is sciatica, common peroneal nerve damage. The clinical presentation is foot drop, and tibial nerve damage means cavus deformity of the foot will be there. In iliohypogastric, ilioinguinal, the root values are important. Iliohypogastric is T12L1. Ilioinguinal is also T12L1. It supplies, iliohypogastric supplies the mons, lateral labia, and the upper inner thigh, whereas the ilioinguinal supplies the groin as well as the pubic symphysis. Lateral cutaneous nerve of the thigh, L2 to L3, anterior and posterior lateral thigh, it will supply, and it will cause pain paresthesia of that area, which is called as the meralgia paresthetica. Genitofemoral is L1, L2, and it supplies the femoral triangle as well as the labia. There will be paresthesias in the femoral triangle or the labia. So this is very important, like the ulnar nerve, radial nerve, Erb's palsy, Klumpke's palsy. Ulnar is origin is C8T1. The medial 1.5 fingers sensory function will be lost, and the small muscle of the hands will be affected, which results in claw hand. And in radial nerve, C5T1, dorsal tips of the lateral 3.5 fingers will be affected along with the wrist and finger extension. So wrist drop will be there. So Erb's palsy, it's very important, and it's very common also. C5 to C6 is there, and waiter's tip. Erb's paralysis, waiter's tip is the usual word used, and Klumpke's, it is CHT1. So here, usually the intrinsic muscles of the hand will be affected, and sensation of the medial arm, forearm, hand, and medial 2 fingers will be lost. It will also result in claw hand. So the important tips for the exam: most common nerve injury after forceps application with urinary and fecal incontinence, mostly it is pudendal nerve. After vaginal delivery, woman can extend knee or flex hip and has absent knee jerk. We know the answer, it is going to be femoral nerve. Women is having foot drop and sensory losses there in the lateral surface of the leg after lithotomy position in surgery. Here the common affected nerve is common peroneal nerve. Erb's palsy, we have already learned now, it is C5C6. Klumpke's, it is C8T1. Nerve injury with self-retaining retractors is femoral nerve. This is a very favorite question of MRCOG. Foot drop after surgery and loss of sensation on lateral aspect of calf and front of foot, common peroneal nerve. Mid-cavity forceps leading to foot drop is lumbosacral trunk is affected. So let's discuss some questions. After vaginal delivery, a woman is unable to extend her knee and flex her hip and has an absent knee jerk. We already discussed this before, and this is going to be femoral nerve. After surgery in the lithotomy position, a woman develops foot drop and sensory loss on the lateral surface of the leg. So the most common nerve affected is common peroneal nerve. 57-year-old para 4 woman undergoes vaginal hysterectomy and sacrospinal fixation. Post-operatively, she develops gluteal pain, which was worsening on sitting. The nerve injured here is going to be the pudendal nerve. So sacrospinal fixation is pudendal nerve. A patient in operating room undergoes surgery during which her arm was extended more than 90 degrees. Later, she is having weakness of shoulder abduction and elbow flexion with a waiter's tip. Which part of the brachial plexus is most likely to be damaged? And it is upper C5, C6. Which incision most commonly risk in ilioinguinal injury? And that is phalansteal extending laterally. Most post-operative sensory neuropathies usually resolve within 5 days, mostly in 5 days. Your talk says it is 5 days. So let's quickly revise the urogenital, bladder and the ureteric injury. during laparoscopy. So bladder injury is incidence is 0.02 to 8.3%. The commonest site is midline bladder dome above the interureteric bar. This is a very important question. Most commonly injured during bladder dissection from the cervix. This is also another important question. So in a previous cesarean case, it is during bladder dissection. Laparoscopy, it is during bladder dissection. But in primary cesarean section, most commonly the injury results during the peritoneal entry. So you may get all these three questions. So this is very important. Injury in laparoscopy, the most common is bowel injury. Injury in gynecological laparoscopy, the most common is bladder injury. Surgery most commonly causing bladder injuries, LAVH. So the bladder injuries are different types, like maybe cystotomy, thermal injury, or sometimes suture might be incorporated. So missed intraoperative injury leading to fistula. Ureteric injuries may occur as transection, ligation, crush injury. Most common is transection. So most common type of ureteric injuries, we already told it is transection. Investigations of urinary tract injury, exam specific area, you will get questions. Post-operative investigation. So post-operative, the most important choice is always CT IVU. Cystoscopy only when VVF is confirmed. Per speculum examination is the initial investigation in suspected VVF. All are questions. Intraoperatively, if you suspect ureteric injury, you are going to push IV indigo carmine and do a cystoscopy. So bladder injury also intraoperative cystoscopy is the first test to be done. Post-operative presentation suggestive of ureteric injury is usually loin pain, fever, ileus, abdominal pain, urinary leakage may be there, creatinine might be raised, and hydronephrosis will be there. Another important question of MRCOG, mostly it comes incidence of ureteric injury at cesarean section. It is 0.03% and incidence of bladder injury is 0.3%. So how do you recognize bladder injury? As we already told, intraoperative like if there is any visible cystotomy, see check for any urine leakage, hematuria. Confirm it with cystoscopy. You may instill methylene blue or indigo carmine dye also. Now, post-operatively, they may present with pain or suprapubic pain, hematuria, oliguria, urine leakage. There may be peritonitis, and you have to go for a CT cystogram to diagnose. So how do you manage bladder injury? So intraoperatively, you have to prefer laparoscopic repair, 1 or 2 layer closure, usually with a 20 or 30 polyglactin and make sure it is watertight closure. You may test with dye after doing the repair. Post-operatively, you have to keep the catheter for 2 weeks, antibiotics for 5 to 7 days, confirm with the retrograde cystogram, and you may inform the patient that the fistula risk is 5%. All points are questions for your exam. Ureteric injury, the incidence is very less, 1 to 2%. Higher with laparoscopic, if there is any conditions like PID or endometriosis, any distorted pelvic anatomy. Common sites of ureteric injury are for gynecological surgeries, mainly at the pelvic brim, where the infundibulopelvic ligament is there, and also the lateral to the cervix, where you are going to clamp the uterine artery or cardinal ligament. Ovarian fossa is also another important site. So how do you recognize? We have to do intraoperatively cystoscopy, see for any ureteric jet, push IV indigo garmin, try to put a stent and see whether it's passing. Retrograde or antegrade ureterography may be done. Post-operatively, the patient usually presents with urinoma, flank pain, fever, hydronephrosis. Delayed presentation 10 to 14 days may also come in thermal injury. So how do you manage? Careful debridement, make sure blood supply is preserved, tension-free anastomosis should be there, use only absorbable interrupted sutures. You have to put stents also after the repair and prefer laparoscopy. And upper third injury, what you're going to do procedure? You're going to do ureterostomy. Middle third, you're going to do ureterostomy or transureterostomy. Lower 1/3 ureteroneocystostomy. This is very important. And for short urethra, you are going to do either a Boris flap or you have to do psoas hitch. So again, so we covered all the important points. Now let's discuss some questions. Most common site of bladder injury during laparoscopic hysterectomy is, we already discussed this, it is going to be midline bladder dome above the interureteric bar. Best intraoperative test to confirm ureteric patency is cystoscopy with indigo carmine. Thermal ureteric injury typically presents later, 10 to 14 days later. So 40-year-old woman with previous history of TAH and left salpingo oophorectomy 5 years ago. Now she developed a right complex mass for which she underwent right oophorectomy 7 days ago by laparoscopy. So she has acute abdominal pain localized to right side. So she is at risk because there may be adhesions after the surgery, and we did laparoscopy, right oophorectomy was done. So mostly it is ureteric injury. Post-TH BSO for endometriosis, again a high risk. Patient complains of vaginal discharge on post-op day. Initial step is, we will jump into 3 swab test, but before that we have to examine by speculum. So examine by speculum is the answer. Which abdominal incision is associated with less postoperative pain? So here we will be discussing the new topic, that is abdominal incisions and also sutures. So which incision is associated with less postoperative pain, reduced febrile mobility and shorter hospital stay? Favorite question of MRCOG examiners, and answer is Joel coin incision. So which statement regarding abdominal facial closure is most accurate? So mass closure with delayed absorbable sutures. So this is an EMQ. Best incision for cesarean section with reduced blood loss. Already told, it is Joel coil incision. Incision providing best access to the space of Ritzius. It is Cherney's incision. Muscle cutting incision is the Maillard incision, and that has got just to inferior epigastric vessels. Most versatile incision for malignancy is midline vertical, and lowest incision in the pubic hairline, it is called as a Moschel incision. So all these things are important. Closure techniques you should know, like primary suture line continuous or interrupted. There won't be any difference in the dehiscence or hernia rates. In continuous sutures, less foreign body reaction and even tension distribution is there. Secondary or retention sutures are basically used to reinforce the primary suture to reduce the dead space, and these are placed 2 inches from the wound edges. Facial closure, mass closure is usually preferred. Delayed absorbable suture is used, and the suture length to wound ratio should be more than or equal to 4.1. Avoid subcutaneous sutures. Special closure techniques are there. One is Med-John's closure. It is called as Fafa-Nyonya technique, and delayed absorbable sutures are used. The dehiscence rate is 0.4%. Gallop closure is another method. And in obese people, we prefer, because of the increased infection rate, prefer midline vertical incision, avoid panniculus, and prefer mass closure and drain, intrafacial drain sometimes, and skin staples. Sutures, important points I have written. It is episiotomy, it is Weichel rapid, polyglactin 20. Weichel rapid, sorry. Tubal recanalization is proline 40. Midline vertical incision, it is PDS 1. Laparotomy skin closure, it's done with Weichel J needle. And mass closure in obese, here you have to use the PDS loop or the Weichel 0. Uterine incision, we all know it is Weichel 1. Rectus, peritoneum, you can use Weichel 1. Bladder repair, Weichel 20 in 2 layers. Ureter, it is Weichel 30. So mesosalpinx repair after sterilization is Weichel 30 round body needle. Now this part is very important. So in a perineal tear, so anal mucosa, you are going to use 30 polyglactin, that is 30 Weichel. For external anal sphincter, it is PDS 30, and internal anal sphincter, it is 20 polyglactin or 20 Weichel. So this part is very important. Internal anal sphincter has to be sutured separately. So these are some features like tissue reaction of various sutures. Tissue reaction for monofilament, it is less, and multifilament, it is high. Knot security is poor with the monofilament, but it is better for multifilament. Infection risk is low for the monofilament, but it is very high for the multifilament. And the examples of monofilament include PDS, nylon, proline, and example for multifilament includes vicryl and the silk. So this is also very important, like different features of PDS, polyglactin and polyglycaperon is there. So PDS, it is monofilament and the tissue reaction is very minimal. Tensile strength is 70% at 2 weeks, 50% at 4 weeks, and 25% at 6 weeks. Absorption time is important here. For PDS, it is 180 days, 6 months. So knot security, moderate here, and uses we all know, fascia, muscles, deep tissue, etc. Polyglycaperon is monofilament, reaction is minimal, and absorption tensile strength is 60 to 70% at 1 week, 20 to 30% at 2 weeks. Absorption time here is 90 to 120 days. And knot security is excellent here. So here, subcuticular skin suture, soft tissue, cosmetic surgery, etc. we may consider. Polyglactin, you know that it is braided or multifilament. Mild tissue reaction is there. 75% at 2 weeks tensile strength and 50% at 3 weeks. This is important. 56 to 70 days, 2 to 3 months for the absorption. And absorption for vicryl rapid is usually 7 to 14 days. Knot security is excellent here. So let's discuss questions again. Which of the following statement is correct regarding the characteristic of polyglycaperon? That is monocryl. So the answer is, we already discussed, it is monofilament. Tissue reaction is less. Good tensile strength and absorbed for 90 to 120 days. 28-year-old primee has a spontaneous vaginal delivery and it is complicated by a right mediolateral episiotomy. You are asked to suture the episiotomy skin layer. Which of the following is the most appropriate suture for episiotomy skin closure? We already know the answer. It is going to be vicryl rapid. So that's all regarding the surgery and the post-operative module. Have a good day. Learn well. Read well. All the best for your exam. I'm sure that you're going to come out with flying colors. Thank you.